over to you, doctor. Please take from here. You may start sharing your screen.
Um, is it working?
Yes, we can see you. Yeah, now it has started. Just a minute. Okay, fine. Yeah, good. Yes,
Okay.
doctor. Yes, doctor, we can see it.
Okay.
Yes.
Okay. Thank you very much. So good afternoon for me. I think that is evening already for you, so quite late.
Right,
Um,
you're right.
and thank you very much for being here nevertheless. So I am going to introduce you to the European Union health policy, trying to present how is organized the European Commission regarding this health policy and which one are the main topics that we are working now, but also the challenges and the difficulties that we have to have a real European Union health policy. So, okay, I don't know how do I do to pass to the next one. No, you have. I have never used Google Meet, so I don't know.
Uh, okay, maybe I'll be able to guide you. On your laptop, if you're using a laptop, please the next button, wherein you shift. The screen, your presentation is visible to us. You just have to change it to the next slide.
But I don't see where is the next slide. Um, so
Yeah,
where?
yes, from here maybe. Yes, correct,
No,
correct.
no.
No,
Okay,
no, that's good.
thank you very
It
much. So,
works. Yes, fine.
well, this is our president, the president of the European Commission, Mrs. von der Leyen. She is also a medical doctor. She is a gynecologist by training, even if she has been a politician for many years. So, in September 2020, in the middle of the COVID-19 pandemic, where we always have once a year the speech on the State of the Union. In 2020, as I said, she said that we need to build a stronger European health union, so that we need to concentrate in health, and that the health was so important or quite important to justify that we add policies on that. If you know, the European Union, when was created in the 50s, 1950s, was the European Economic Community. So the main focus was economy, was the trying to recover after the war, the Second World War, and to create a unity or a space, a common market for economy. So health was not in the initial intentions of the European Union. And it takes until 1993, that for the first time was introduced in the treaties with one specific article. So the president saying that we need to create a European health union, so a European Union of health, was quite important, given the signal that we were going to move through more intensive activities in the area of health. This is the European Commission, the commissioners, the college, what we call the college of commissioners. So we have one commissioner per member state. So in total, 27, including the president. So she is the president of the commission, and then we have the first vice president, Franz Timmermans. He's Dutch, and we have the executive vice presidents that are Vestager and Dombrovski, and well, in total, as I said, 27 commissioners. The commissioner for health and food safety is Stella Kyriakides, that you can see there. She is from Cyprus. She is a clinical psychologist by training. So when the Commission, the European Commission, this Commission entered in functions, that was at the end of 2019, so will be renewed in 2024. That means that we will have elections in May or June next year. I see that you have begun to put question in the chat, so I will answer at the end. if possible. When the Commission entered in function, this Commission, 6 big priorities were mentioned: the European Green Deal, Europe fit for the digital age, economy that works for people, a stronger Europe in the world, promoting the European way of life, and a new push for European democracy. So the health policies under the promoting the European way of life. There has been a lot of discussion around that. Not all of them were nice, but that doesn't mean that we are eliminating the rest of the world. That means that we try to pass some of the messages that in health are very important, that are, for example, the universality in the access to healthcare, the equity, and the quality, that we are trying to pass this idea to the whole world, and that will be done especially through the global health strategy. You know that there are many countries in the world, some of the most developed, including, that don't have universal health access, and we do. So we try also in our policies to support this universal health coverage, universal health access. Which one are the functions of the European Commission? I mean, we are like the government of the European Union, but we have 2 co-legislators. So we don't do the legislation. We propose the legislation, and we check that the legislation that has been adopted is taken into account and is implemented in all the 27 member states. But the ones that have to approve the legislation are the Council, European Council, and the European Parliament. So what we are the ones that propose, and also what is called the guardian of the treaties. So we check that everything that has been approved enter into force, and that is honored by all the 27 member states. This is DG Sante. So the European Commission is established in different services or general directorate, and this is DG Sante, that is health and food safety. So we have the Director General and 2 Deputy Directors Generals. That this one, Claire Goury, is Deputy Director General for Food Safety. That includes also animal health, food sustainability, and John Ryan, that is the Deputy Director General for Health. So we are established in 8 different directorates. I am here, by the way, you cannot see very well, but I am a principal advisor to the Deputy Directors General. So there are 8 directorates, of which 3, those 3 are for health, public health system, and pharmaceuticals and medical devices. So apart from that, we have 2. Well, this one is for One Health and includes all the international area. 2, this is the general services, human resources, and money, and similar things. Then there are the directorates that are in charge of food safety, etc. I will share the document on PDF at the end. Or tomorrow when will be possible. So and so we are the Director General for Health and Food Safety, and we have different agencies. So we have independent agencies, but that also are part of the European Union institutions, and that are in charge of different specific areas. One that has been very important during the COVID-19 pandemic is the ECDC, the European Centre for Disease Prevention and Control. And those are decentralized agencies. That means that, in general, they are not based in Brussels. One thing that I forgot to say is that DSANTE, this General Directorate for Health, is based in 3 different places: in Brussels, in Luxembourg, and in Ireland. So in 3 different countries. And we are more or less 800 people. So those agencies, some of them are very big, like the European Medicines Agency, and some of them are very small, like the Community Plant Variety Office, are outside. This is in Amsterdam, this is in Stockholm, this is in Parma, Italy, this is in Angers, France, and this is in Copenhagen, and this is in Helsinki. So they are outside, and they have one specific function. In the same way that the Commission is a general government, so it's for everything. Then divided in general directorate that take care of some specific policies. These agencies take care of very specific part of a very specific policy. So the ECDC is like other centers for disease control, is making mainly the surveillance for the diseases. The European Medicines Agency is doing the scientific approach, the scientific advice on medicines, both for human and for animals, and now is beginning to have some competencies on medical devices. The European Food Safety Authority give advice on food safety. For new plant varieties in the European Union is support the patents for plant varieties. And then these two agencies, Environment Agency and Chemical Agency, they don't exclusively depend on DigiSante. DigiSante is as health and food safety. But we work with them and we have some competence. These four European Union agencies depend exclusively on the Sante. We are what we call DG de tutelle. So they depend on us, and even if they are independent, at the end, we are providing the budget. And then we have an executive agency that is the HADEA, Health and Digital Executive Agency, that what is doing is no legislative competence at all, no policy competence at all, but is the implementation of the funding that is done through the European for Health program, so our funding instrument. So that means that we as DigiSante, we have two main areas of competence. In one side is the public health, with our main objective that is to build a strong European health union, and we need to focus on crisis preparedness, pharmaceutical strategy, and the European beating cancer plan to provide accessible medicines for everybody in the European Union and implement a new regulatory framework. So we are the public health. So we have two quite separate areas of work on the food safety, animal and plant health, but that both meet in what we call the One Health. The One Health. Okay. So some of the questions I will try to answer because they are quite specific. The funding we have we have what we call the administrative funding. So the funding for the DigiSante, the people that are working in DigiSante are the administrative costs that come from the general budget of the European Commission. So it's like any government. The government of the European Union has a source of income that come from the member state and from some specific taxes. And then we have not all the general directorate, but most of them have programs. So is the EU for Health, the health program was called before, and that all those are 7 years programs. Why 7 years and not 5 as the government of the European Union? I said that this commission entered in 19 and will stay until 24. Why the program is not 1924? In reality, is 2027. Why? Because otherwise everything will be stopped. if the projects were at the same time, the programs were going at the same time that the government, that the European Commission, at the beginning in 19, for example, we have stopped until this new government enter in force and begin to make all the plans and will end at the end. So there, what we try is that there is an overlaps and that every government that enter in the European Union is not just planning for that, but for a period that is longer. So the multi-annual programming that we call is for 7 years. And the money, the funding come also from the member states. We have a budget in the European Union that is approximately less than 2% of the GDP of the European Union in total, but comes mainly from the member state and also from some specific taxes that come directly. I saw, well, the question about global health, we will discuss later, and also the difficulties on working with 27. What I wanted now is that you understand that there are two separate areas of policies, but that both of them converge mainly in what we call One Health. One Health because there are issues that affect the animals, the food, and also the health. But I'm going to talk about the health part because food safety is not my domain, and because I was requested to talk just about EU for Health. So our legislation is the Treaty of Functioning of the European Union. So the Treaty of the treaty, what we call the treaty, is the Bible. So our basis, our legal basis. This treaty gave the competencies to the member states or national competencies or European Union competencies according to the areas of work. In health, as I said before, this was not an institution. The European Union was not for health, was not intended for health at the beginning, and has been quite reactive. And also in how we introduce health in the treaties and in the activities of the European Union, you need to take into account the background. So this European Economic Community. So if we take into account what is the main competence of the European Union, is to support an internal market. So, and to guarantee that the products could cross the borders, the internal borders, the national borders, so inside the big border of the European Union. So everything that is inside the European Union as such can go from one place to another independently of the national borders. So what is crossing borders in health? The health products mainly, so the medicines, and this is why we have a strong pharmaceutical legislation. The medical devices that goes from glasses to tag machine, so they could cross borders. A substance of human origin, like blood, tissues, and cell organ, they are crossing the borders, and among others. But I mean, the main one. We don't have as competence to put the same conditions of commercialization inside the European Union. But what we have to guarantee is that the products that are commercialized inside the European Union have all the same quality and the same safety. So our competence is to guarantee that the medicines that are put in the market in the European Union are safe and of quality. We don't enter on how they are going to be reimbursed, and if the different countries have to have different policies on what is covered by the health system. This is not our competence. Our competence is that they can cross the borders and with the same quality and safety for everything. So in health and inside the treaty, there is one article, the health article, that is the Article 168. The 168 says two very important things. Well, several, they have seven paragraphs, but the most important to understand what we do is the first one and the last one. The first one that says that high level of human health protection shall be ensured in the definition and implementation of all union policies and activities. That means that we need to check the health in all policies and that take into consideration how other policies can affect health. And when designing a new policy, take into consideration the impact on health. And the last one that says that we need to respect, when we are acting at European Union level, we need to respect the responsibility of the member state for the definition and the organization and the management and the financing of the health system. That means that each member state is free to organize the health system as they wish. So there are countries that have a national health system. There are countries that are based in a social security system. They are countries where the provision is completely public and countries where the provision, independently of the financing, is private or a mix. They can do what they want. They can cover with the national health system or the public finance every medicine that is put in the market, or they can decide that they need to submit every medicine not to be put in the market, because once that has been approved by the Commission after the positive opinion of the European Medicines Agency, uh, can be put in the market, but that is reimbursed and introduced in the packet of benefits of the national health system or the public health system. So we need to guarantee those two things: the level of health protection and the respect of the national rules. And here is where the tension that was in one question in the chat at the beginning, how we compatibilize the idea of European Union, European Health Union, with the different competencies of the member states. Sometimes there are difficulties, sometimes it's easier. And usually we have to take into account this Article 168 as the article about internal market and the other policies. Another issue that is important is that, as I said, that we were not a European Health Union at the beginning, but an economic one. We are in health, we usually have been reactive and not proactive. So in the 60s, 1960s, we had the issue of the thalidomide, the medicine. As a result, we created the legislation on the pharmaceutical legislation. We began to work on pharmaceutical legislation, and then we created the European Medicines Agency. We had the scandal of the HIV/AIDS and the transmission by blood. And as a consequence, we put a legislation on quality and safety of blood. And this was also jointly with other issues came the creation of the European CDC. We had the issue of the mad cows in the 90s and 90s 2000, and we reinforced the legislation on food safety. So, and now we had the pandemic of COVID-19 years ago, and as a consequence, we have reinforced the legislation on health security and the legislation of the ECDC, EMA, and also the cross-border health threats. So until now, we have been more reactive, and now we begin to be a little bit more proactive. But because we have an history of many years that we need to work with. So How we work on health in the European Union. We have three main ways of working: legislation, so obliging, coordination, and financing. So those are our three ways of action. Legislation, where do we have legislation? On the things that cross border. So in the health products. The health products, so the pharmaceuticals and the medical devices, and for that we have a lot of legislation on pharmacovigilance, on falsified medicines, on how to do the clinical trials, and now the more recent is about the health technology assessment. Um, we have legislation on organs, blood, tissues, and cells. I already talked about that because they are health products, also substance of human origin. We have legislation on tobacco. This is curious. I mean, curious, could seem curious because it's not a health product, but it's a product that affects health. And we have legislation, not for example, on a smoke-free environment. We cannot, because I said that what we are regulating is the product. So we have legislation on how the boxes have to be, the pictorial warning that are in the boxes, the content of the tobacco products. I mean, what is inside, but who and where and when can smoke is for the member state to decide. But we have a very strong legislation on tobacco. And also it's important, for example, for the framework convention on tobacco control, it's not just the member states who are parties. The European Union is a party. And we speak with one voice there. We also, who else cross borders? The patients. The patients can cross borders. And we have legislation on the patient's right in cross-border healthcare. So they have some rights to the provision of healthcare that is reimbursed by the country of origin when they are going to, and they can go to another member state to be treated and paid by the country of origin. We have the new health security and infectious diseases legislation. We are developing in digital care because also the data are crossing borders. And also we have what we call soft legislation, that is instead of directives and regulation, we have council recommendations. For example, on cancer screening, or on smoke-free environments that we have recommendation, but it's the member state who decide that they want to work on that, or on vaccination, or on other different issues, but they are what we call soft legislation. And which one are the main areas where we are working now that make the EU health policy currently? The first one is evident: health security. Health security, because we had enough problems in the last 3 years with the COVID-19 pandemics, and we saw that we need to reinforce. So we passed from a Commission decision that is in the I don't know how the order of the different laws and rules is in India, but for us the maximum is a regulation, EU regulation. Then is the directive, and then there are other pieces of legislation, and a Commission decision is legislation, EU legislation, but is in the basic level. So we have passed from a Commission decision to a regulation. What is the difference, for example, between a regulation and a directive? I mean, it's not very important for you, but that you understand that a regulation enter into force immediately. What is written, and that's it. When there is a directive, the member states have to transpose that to the national legislation. But a regulation enter into force could be immediately, and nothing can be done. So for the health security framework, health security, we have now a regulation on severe cross-border threats to health. What we have reinforced is that the surveillance, the risk assessment, and the risk management, and also we have given more competencies to the ECDC and to the European Medicines Agency. For example, One of the issues that we have with medicines, I said that we are authorized, that is put in the market, but sometimes there are shortages with the medicines. And these shortages was nobody competence to check. I mean, it was for the member state to know what was happening in the geographical area. But at the European Union level, now the European Medicines Agency has acquired this competence to check how is going the market. Another issue that I said is once that a medicine is approved to be put in the market, the company can put in the market, but does not have to put in the market the medicine. So not in all the member states, not at the same time. Now this is going to change. We are going to discuss the new pharmaceutical legislation, but the European Medicines Agency will have the competence to check when and how a medicine has been put in the market. We don't intervene in the prices yet. Another issue that we suffered during the pandemic is that we didn't have the precursors of the medicine, and this is why, for example, we didn't have paracetamol. And now this is going to be checked and reinforced with this health security framework, because we are going to define also which one are the the potential threats and the critical entities that we need to protect, and to be clear that that we have the adequate means. So we are reinforcing all the health security, internal health security, but also working in the global environment that are affecting that. This has been our main activity in the last 3 years to reinforce the health security framework. We have also created a European Health Emergency Preparedness and Response Authority. This is not an agency; it's a general directorate of the Commission, but we have called to reinforce this idea. We have called the authority HERA, and that is not a bar down, as in the United States, even if has some competence there, but that mainly what their competence is the mechanism to check and to prepare for the mechanism of response, and to ensure that all the member states are prepared for next emergency. We hope no, but and also to work on the joint procurement. So to ensure that we have sufficient supply and that we are prepared also to develop the new treatments or diagnosis of etc. The pharmaceutical strategy, that is very, very important for the European Union. We have approved a new pharmaceutical strategy, a new package of legislation, of proposals last week, last Friday. Thursday, the 27th. So what we have approved now is a new proposal. The Commission proposed, remember, and now went to the Council and to the Parliament. The Council and the Parliament have to decide if they want what we have prepared, and now we are ready for 1 year of discussion, at least, until we have a new legislative package, a real one. So we propose, they decide. Why we have proposed a new pharmaceutical strategy and a new package? First, because the current one is from 2001, so 20 years. Second, because the current one also includes some provisions on orphan medicines, in pediatric medicines, and in advanced therapies medicine that need to be revised. Because could be improved. Taking into account the evaluation of this year, this nearly years of activity, we want to update the legislation. Then we want to ensure that the patients, the citizens of the European Union, have access to the affordable medicines. I said that The medicines are not at the same time in all the markets, and even in some cases they are not in the market. For the pharmaceutical companies, of course, it's not the same a market like Germany with 60 or 80 million people than Malta with 500,000 people. So sometimes the access of the EU citizens is not the same, and we need to guarantee that. Second, because we have deficits in some medicines. You know that everybody is very interested in developing new medicines for cancer, but not everybody is interested in developing new antibiotics or medicines for neurodegenerative diseases, for example. And we have that need, and so we need to see, or we are trying to see the incentives for the pharma companies to develop these new medicines that we need, but at the same time guarantee that these medicines can go to the citizens quickly, not too expensive, and in an equal way. So we keep for sure the high level of quality and safety. This is not negotiable. But we need to discuss with everybody, with all the stakeholders that are the pharma companies, but also the patient association and the citizens association. It's going to be a difficult discussion, a difficult legislation. But well, you can see some numbers here about the sector. It's a crucial sector for the European Union economy. I mean, the pharmaceutical sector is very important for us. We are for the equivalent, the FDA, I mean, the equivalent to the FDA is the EMA, the European Medicines Agency. But the difference is that we approve. The EMA does not approve the medicine. They give them assessment and let's say the okay. But we have really to sign. But the EMA is the one that is controlling all the clinical trials and etc. For the medicines that are authorized at central level. The generics, for example, are not authorized at central level; they are authorized at national level. So it's an important in volume of the GDP what we spend in pharmaceuticals, but it's also important in the number of companies that are established in the European Union. Sometimes we are conflicting with other countries on the world, but we are not ready to diminish our standards, and also and other issues that we are not ready to compromise, like the information to patients, for example. But this is a very important sector for us that we don't want to lose and continue with the establishment of the companies in the European Union. An important area of action is the Europe's Beating Cancer Plan. So we have developed in the last 4 or 5 years an action on cancer that is not just from DG Santé, it's also DG Research. So take into account the research on cancer, not just the screening, diagnostic, treatment, rehabilitation, but everything. So we work in a very transversal area in all the areas. I mean, from prevention to early detection, diagnosis, and treatment, and also in issues such as the right to be forgotten by the cancer patient and the survivor, so that it's not always attached to a person that has been a cancer patient and cannot contract an insurance, for example, or will not be allowed in one employment because the employer could be worried that this person is going to cost them a lot of money if has a recidived and need to be treated, etc. So but we are developing, and also, as in all the European Union policies, inequalities in access, inequalities in screening, is something very important for us. We have just approved, the council approved in December a new council recommendation on cancer screening. The previous one was recommending the colorectal, breast, and cervical cancer, and now has been extended to other three cancers that are prostatic, lung, and stomach, when it's advisable because of the numbers in the geographical territory. So this European Beating Cancer Plan has different flagship initiatives, like could be the cancer screening scheme that I have mentioned, or the Better Life for Cancer Patients initiative. We are also establishing a registry for cancer inequalities, and we are establishing also the European Cancer Imaging Initiative. Well, those are what I have mentioned about the cancer screening. The health data space. I mean, this important is still a proposal that is currently being discussed in the Council and in the Parliament. I mean, European Union citizens are traveling all the time and are traveling inside the European Union. This is something that we cannot legislate for outside, but inside the European Union, they are moving because they are studying in another country, or go to live and work in another country, or they are going to holidays. And what happens is that there is no access to the health data. If you become sick in another country that is not yours, sometimes even if it's in your country and in a different region, you don't have access to your clinical history, to your records. So taking the patient as the center of the system, and that the control and the access is for the patient, we want to facilitate this access, and to have a real single market, so internal market for the digital health services. This is quite difficult, complicated, because it's not only the legislation, but also the technology, and establishing similar technology, or even if it's not the same, that is the compatibility of the different technologies. So it's something that we have been discussing in the Council and in the Parliament for almost 1 year, and it's advancing slowly. Medical devices jointly with the medicines, even if they are regulated in a different way, are the important medical products that we need to treat our patients, to treat and to diagnose our patients, because medical devices are really very diverse. So we have since 2 months ago entered into force the last laws that are governing the medical devices in the European Union. And one issue that we need to control is the shortages and the disruption of supply. Everybody is aware of the issues that we had with the surgical masks, for example, during the pandemic, but also with the diagnostic tests, so that are also medical devices. So this is one of the areas where we are working, and that we want to avoid that this happens again. The substance of human origin is something that is currently also on discussion on the Council and the Parliament, and so that we propose, and has been discussed for a while. We are extending this definition of the substance of human origin, for example, to issues like the breast milk, that is a substance of human origin that is also shared. We keep the high standards of safety and quality, and we are putting order in the medically assisted reproduction, and because we have from the cells to the embryos that they are substance of human origin, that the previous legislation was not implemented by everybody. And we improve the patient access to the therapies that they need, and also taking into account that those products, the safety need to be checked, and that we need to make to improve the surveillance of on these issues. That sometimes is a surveillance. I mean, something that is not immediately seen when something could be transmitted via one of the sharing one of these products, but comes sometimes later. The EU Global Health Strategy, we are in the war at the end, and we have seen that with the COVID-19 pandemic, we are not alone. Of course, this is, I mean, basic thing, but we were in the years before, we were working quite just for inside the European Union. And so now we see that not only the threats can come from inside, from outside, so we can acquire, we can transmit to the external world. We need to transmit, as I said, some of our values like the universal health coverage, but we are also working with the international organization in the international health regulation or in the pandemic treaty. So we need to work in the global health. The funding for all our policies come from the EU for Health. That is the program 2021-2027, 7 years, as I said. In order you to have an idea, the previous one, the 2014-2020, had 460 million. The current one is 5.3 billion. So we have multiplied by 12 the funding that we have for health. This is, of course, consequence of the pandemic, as we were negotiating that in 2020 when all this began. And if we want really to make a European Health Union, we need to reinforce the funding. We work in these 4 areas that you see: improve and foster the health in the European Union, to tackle the cross-border health threats, strengthening the health system, resilience and resource efficiency. The health workforce is one of our weakness, and to improve the medicinal products and all the products that are related to crisis. This is all that I wanted to tell you. And now I think that I could go for some of the questions that you have
Yeah.
made.
Very thank you, Doctor. Before we take up question answers, I think I would like to tell you that we have among us Professor Monica. Professor Monica has been, she's a pioneer of Europeanization of health, and she started to investigate the role of EU in the health since AIDS pandemic and the blood scandal. So she's with us, Professor Monica. Welcome to you. So I thought, because we did not introduce you in the beginning, so I thought let me introduce you to Dr. Dila Mata. So, ma'am, before I ask Monica to share her views on today's presentation, I would like to thank you very much for such a nice and wonderful presentation, and it was very informative, and I'm sure the participants would have learned a lot from it. I think I can take up a few questions if you have some time, Doctor.
I have seen in
Okay,
the
you can
chat.
see it in the chat box. Then maybe should I read it out to you?
Yeah, so if I can go in order, the first one is
Yes.
from Stefano Greco. Creating a European policy in health, what is the biggest obstacle in bringing the 27 national government on the same page? I mean, this is obvious. I want to work for me, my country, and what happened in the rest will come later on. So is this tension between yes, the European Union and the national policy, and one of the issues that I mean, as I have been working in a national government before coming to the European Union, that I always discuss with my colleagues, is that a politician is never going to lose an election because something that happens in the European Union. Is always going to lose an election because something that happens in his or her national area. So it's more interesting for the national one. And then the tension is that the treaty says that we need to respect the national competencies, and while also keeping, now we are not in the same place that we were 30, 40, 50 years ago. When a disease affect one country, immediately in 2 hours or 2 days or 2 weeks is in another country across the border. So we need to work like a European Union or international the international work, but sometimes it's not easy. One of the weakness is also the funding. We cannot fund everything that is going to be implemented in the different member states. We have some money to fund some initiatives, but we don't have money to fund any new vaccine, for example, because I have seen that there is a question about that. So there is tension. To start initiative with the Indian counterparts, we already have some initiatives. I mean, we have in the EU delegation in Delhi, there is a colleague that comes from the from DG Sante, health and food safety, and we discuss with the national authorities. Now we are preparing the World Health Assembly, and we are discussing about initiative from different parties. We are involved also in the G20, G7, of course, but also G20 initiatives. We have been discussing the issues on pharmaceuticals with the Indian authorities, because there was this issue of forbidding the export of the active ingredients for the pharmaceuticals. But we collaborate in other issues, and it's not only the Sante. We have other general directorates like the international partnership of the ECO for emergencies. So we work with other countries. The surveillance for potential health by migrants. In principle, our position has been that migrants don't bring diseases. Migrants acquire diseases because of the conditions in which they live when they arrive, and they especially when they are irregular ones and don't have money and don't have access to healthcare. And in any case, we do health assessment of the people that are arriving, and the first thing that we do is to offer the inclusion in the vaccination program, not only for the children but for everybody. The crisis, the migration crisis that we had in 2015 because of the issues in Syria, in the same way that the current one because the war in Ukraine, has teach us how we need to deal with the displaced person. But we haven't seen an increase in disease X or disease Y. The changes in the pattern of the diseases mainly come because of the climate change. One of the issues that we have identified, for example, is that some diseases that were more prevalent in the Mediterranean area and that we were controlling, thalassemia, just to say, but they are chronic diseases, they are blood diseases, they are not communicable diseases, have increased because of the movement from people from other countries in the Mediterranean, but we had already established the management of this project quite well. Women's empowerment in the health sector. Okay. Well, we have a strategy, a gender strategy. I mean, the health sector is quite in the hands of women, but there are not many women that are in the power. We have checked that during the COVID pandemic. I mean, the commission, by the way, was the one where the president, the commissioner, the director general, and I, that was the one going to the council to the instruments for crisis. We were all women when other countries was not like that, and there were very few women that were health ministers or even prime ministers, even less. And we have checked in some other areas like cancer. And one thing that, for example, quite shocking is that while there are a lot of almost the 95% of the nurses are women. For a long time, the representative of the nurses in the European Union has been a man. So that we need really to work in the empowerment of the women. But at the same time, it's true that when more women begin to be in one sector, the level of economic win, I mean the salaries, for example, is because if they have decreased and women tend to be in sectors where the working conditions are easier, or and usually this is linked to a lower economic level. So something that we need to work. We have, as I said, this gender strategy that we are trying to apply horizontally also through the commission. Immunization, no, we don't have. This is a national. I said that this is a national competence. The management of the health system, the organization, the policies, the access, everything is a national competence. What we have been trying is to coordinate at least the vaccines that are applied in all the countries. A minimum of vaccines that they are applied more or less at similar ages, but it's not always possible because sometimes it's linked to the school, when primary school begins, and then one secondary school, and this is different in the different member states. But we have been working a lot since, especially since 2017. Why this at that moment? Because there was several outbreaks of measles in the European Union, and so we were really concerned that something that was supposed to have been eliminated of the European Union in 2000 was still going on in 2017 with several deaths also. But so not the same vaccine. I mean, the classical ones are given to all the children, polio, DTP, but hepatitis not in all the countries, hepatitis A and hepatitis B. The HPV now is in all the countries, but not in all the countries has been implemented for boys. There is not common position on which vaccine is given at 14 years in DTP combined with polio, and etc. Have the Eastern European nations catch up with Western European in terms of health indicators? Well, sometimes they are doing better. It depends which indicators. We have some issues with vaccination coverage in two specific countries, but not really in the others. For maternal mortality, I mean, the situation is so good. I mean, the mortality is so low that we have recently an issue with some of our politicians because said that maternal mortality had increased in 50% in some countries. So, well, no, I mean, yes, in terms of numbers has increased 50%, but because we have passed from 4 deaths to 6 deaths, yes, has increased 50%, but this is nothing. 6 deaths by 100,000 because of the maternal mortality, when also the age of the mothers is increasing, and also the number of medically assisted reproduction that sometimes have an increased number of problems because of the age of the mothers and the conditions in which the mothers arrive to that to the medically assisted reproduction. So yes, different countries in the all the countries in the European Union has an immunization schedule. We are checking constantly that is the ECDC. There is a web page that is called the immunization schedule, where you can compare by country, by vaccine, by how the situation is. Stewardship to strengthen the respective health system. Yes, sure. We have something that is called, we have several mechanisms. One is called the European semester, where we check every 6 months the reforms that the member states are implementing in all the areas, in all the government areas, including health. So we are checking and giving recommendations to the member state. We also have the health system performance assessment groups. We have the health technology assessment group, so that where we are always checking with the member state and discussing with the member state, and we don't necessarily say you need to do this in this way. What we give is the recommendation: you need to modify the primary health care. In general, I think you should, I don't know, implement longer hours of opening or something like that. But for these specific issues, we have a specific support, technical and financial. We work a lot with the European Observatory on Health System and Policies, and we work with the one general directorate in the Commission that is called DG Reform. So I think that more or less I have answered everything, but if you have something else, please let me know.
Thank you very much. Yeah, I think that that should be sufficient. You have been very, very patient, and you provided detailed answers to all the questions put to you. Thanks a lot. Thank you very much. So before we end today's session, I would like to have a last word very quickly from Professor Monica and Professor Stefano, one by one. So Stefano, if you could, okay, Professor Monica is there. So Monica, if you could start about today's session. If you have to add anything to it, please go ahead. Then it will be over to Professor Stefano.
Thank you very much. Can you hear me?
Yes, we all hear you. Yes.
First of all, and that's the most important, not to forget, I thank you very much, Isabel, for this wonderful presentation. It was so clear, so interesting. I've heard quite a lot of presentations about the European Union and health policy, and it is complex and rarely so clear and so complete also. So I know we will have your slides, but the question is, I would have liked your talk recorded. Is it recorded, Stefano? May we have access even if
yes,
it is restricted?
Yes,
I would like to listen to it again. It's so clear and it was so rich. So that was my first remark, to thank you very much, ma'am, as we say in India. The second thing is I noted a very important thing I saw on your cancer program. I didn't know and didn't look into it. It's all very up to date and new. The priority really after institutional things, the public health priority was vaccination against the papillomavirus. And I think that's extremely important given the figures of cancer that virus is causing, and we have a vaccine. And there's a lot of anti-vax people in Europe who don't want to get their children vaccinated, and they just don't know what they're doing to their children. So thank you very much to the European Union. You should find some way influencing national governments to maybe the doctors should talk more about it, but I think they do. Maybe it should go through the schools directly to the young people. I don't know what you should do, but that's so important. And it's important for women because most of these victims are women. So that's the other thing. And then I would like to make a proposal to Chitkara University and to the European Union. I have noticed in this presentation we had, I don't know now, now we still have 90 participants. We had 96 in the middle of it, so a few people must have left, but it's very few. So this is absolutely maximum, Stefano. I mean, this is the professional course, no? We have 10 people enrolled in it, and now we have 90 people, 96 people listening to us. And I also noticed that in the professional courses here, whilst I was in India, the level was quite good, quite high. So the proposal would be, as the European Union has now a strategy for health worldwide, I think India, and I also think of Brazil, may be sort of privileged partners for it, because these two countries, Brazil and India, they have a lot of advantages where any collaboration with the European Union would be much more fruitful than in many other countries, because both have huge populations. They have, in part of their population, a high level of education. They do have doctors, so it's not like some countries, in the middle of Africa. So it would fall onto fertile grounds. They are democracies, which I think in the present context we are living with the BRICS coming up under Chinese and Russian leadership may be a major geopolitical point. And they have a big pharmaceutical industry, which would be helpful worldwide, not only less for us maybe, but also for us and for the rest of the world. And I insist on the democratic political regime, more or less. And so I think Europe should maybe concentrate a little bit of its effort for health on these two countries, because they have steps to have public, to have how do you say, universal healthcare access, but they can't get there because they have a lot of private health insurances and business interests in these fields. And they take their recipes more or less from the United States, who struggle out of this, but the lessons are still that you have to have these private institutions. So maybe Europe could bring them a lot, and it would fall under fertile ground. So I think India would certainly, and they are federal countries, so that's very similar to the European Union, with the difficulties with 27 countries. And they have, states and big, huge territories, and they have a lot of poor people, and they have to overcome social division and stigma. In Brazil, it's all these poor people with slave descendants, and in India, it's a caste system which you can still feel. So I think these two countries would be really an interesting field for investing political collaboration around health for the European Union. So pick up priorities. And they have institutions which are quite ahead in research in public health, like the Fiocruz organization in Brazil. They really do good work, and they are in some fields quite top level, and they may learn from each other also, because I don't have the feeling that India and Brazil are sort of very much in direct collaboration around health and research in public health, but they may learn a lot from each other. They are tropical countries, so Brazil has a lot of research on tropical illnesses. So there's a lot of, I think, good prior conditions for fruitful work with these two countries. And maybe there could be something like, I see Stefano will shout, no, I have already enough work. But there could be something like professional universities being set up in these countries, 2 or 3 of them, where you would not train initial young students who do not yet where they go professionally, but professionals, people who work in the healthcare sector, whatever their discipline, whatever their level, from nurses up to researchers in public health or clinical doctors, and do what we are doing in this course, to do it in these in a broader countrywide sense. That would be really nice. And I think in the end we could also learn in Europe something from these countries, and maybe even get them more connected to our universities or our public health institutions, people from India and Brazil. I really believe that would be a good collaboration. And the way to get there could be just multiply this type of seminar. I mean, if we do it once a year, and we would do it in 2 areas in Brazil, and we would have 200 students, professionals, and in India also, it would spread out. It would be a big power of diffusion inside the networks that count in these countries, and we could get our European human values for health maybe across these borders, across the oceans. That's all I wanted to say. With a big thank you to Ma'am, Ma'am Isabel Ma'am, for the nice presentation, and to Stefano and Menashki, who organized it all. Thank you.
Okay, thank you, Monica, for contributing to the discussion. That was a few points which I feel would have gone down the line very positively. So, Stefano, it's over to you before I end it.
Okay, so I just want to say a big thank you to Isabel. Thank you so much, Isabel. And about this, I can just tell you that we are waiting for you in here. Okay, so we are actually waiting you to come in here. Okay, I hope that actually DG Sante, it is actually planning to come in here in India. I have actually personally met multiple time, no, actually Benoit that is in here, but I guess that he would also need your support, because in India, China are the two actually cross point when it comes to emergency. It is really important to come in here and try to help the actually local governments to try to just, how to say, improve health policy and public health in here. It's something that we need to do together, because the health is one as the planet. Thank you so much. Thank you, Isabel.
Okay, thank you, Isabel. I hope you are going to accept the invitation given to you by Stefano, and we hope to see you amongst us very, very soon. So, and we'll be looking forward to that moment. Thank you once again, everybody. Thank you for joining. The odd participants today were the healthcare professionals as well as the master students for hospital administration. So we had few budding future administrators for healthcare, and we had the working professionals as well as today. So I think each one of you would have gained by every minute you spent listening to this today's presentation, and everybody would go back happy that their knowledge has increased. So thank you once again. I think if anybody has to ask anything, please raise your hands, else we are going to end the meeting here. Thank you everyone. Thank you, Professor Isabel. Thank you, Doctor. Thank you, Stefano and Professor Monica, everyone. Thank you.